Welcome back. We're here for lecture 24, and we're now going to turn our attention to embryology, the development of the upper limb in particular. And we're dividing this into two segments. In this first segment, we're going to look at intrinsic causes. Intrinsic causes essentially referring to something within that limb, within the developments, the genetics that comes from within that own organism, from within that limb, that lead to limb malformations. In the next lecture, we're actually going to turn our attention instead to extrinsic causes of what we would term limb deformations. Deformation being the proper term essentially for where something outside of the limb itself causes a change to the morphology, to the shaping and development of that limb. So again, for this first one, we're going to focus though on the intrinsic causes. And here's actually what I think is a beautiful example of looking essentially at this embryo during development. And during development, just to point out some of the key features here, we can see the upper limb bud just starting to form here. We also see the lower limb bud starting to form. It usually forms just slightly after the upper limb bud. And actually, this comes from an ectopic pregnancy that was remarkably preserved when they removed the fallopian tube. You can actually see here essentially some of the lining of the fallopian tube around the outside. And this basically is what would have been developing as a fetus in the wrong location, within the fallopian tube of the uterus, instead of within the body, within the main cavity of the uterus. So, all right, let's take a look at some of these stages of limb development before we look at some of the things that can go wrong here. So when we start having the upper limb develop, it usually occurs around 32 days of gestational age, so about a month gestational age. And the first thing that we'll see is a flipper-like upper limb bud. Essentially, no real detail here, no separation of individual digits, just an outpocketing essentially from the lateral portion of the developing embryo. We'll then see a couple days later that the hand plate will form. You see this swelling essentially at the most distal portion of that limb bud, which will ultimately be turned into the hand. A little bit more than a week later, we start actually getting some of that formation of the individual fingers. So here we have what are termed digital rays showing up in that hand plate. The digital ray essentially being what's going to become the finger. But notice that the web spaces here, the area between adjacent fingers, really is more or less still intact. We're starting to form a little bit of a notch there, which ultimately through apoptosis or programmed cell death, that entire web space will be lost. We'll have essentially destruction of those cells to be able to create differentiation or separation of these fingers. But at the early stages, essentially, even though we have a little bit of this digital ray forming, we haven't really separated the fingers in entirety. A few days later, though, we are able to see a little bit more of that detail. Also not very well shown in this diagram, but we do start seeing a little bit of a bend to the upper limb, mainly from the beginning of the formation of the elbow joint. And as pointed out before, again, the fingers themselves are still relatively short. There are still web spaces between them with tissue, but come about again 1 week later at 56 days, those fingers and toes are more or less distinct and separated into individual digits. So limb development, again, essentially we have an outward growth here of the limb. We have that formation of that hand plate. We start getting formation of the individual fingers through those digital rays and those notches that form and ultimately become the completely removed web spaces between the digits. And we start actually getting the formation of the elbow joint as well. So let's take a look at the limb bud itself. The limb bud contains two of the three primary germ layers, those two layers being the ectoderm. The ectoderm essentially forms the external structures to the limb, things like skin, things that are within the skin like sweat glands, apocrine and eccrine glands, which form some of the different secretions that ultimately are going to be on the surface of the skin. Hair and other appendages like the erector pili muscles, those being the very small muscles that actually cause that hair to raise up. So when you have goosebumps, that's what's causing that, little erector pili muscles causing that raising of the hair. The mesoderm is also a layer here. The mesoderm mainly becomes tissues that are more internal within the limb, things like muscle, bone, the blood vessels themselves, and connective tissue as well. What is not included here is going to be the endoderm. The endoderm is a layer that does not exist within the limbs. It does contribute mostly to some of the internal organs. So it forms the GI tract, the organs that hang off of the GI tract, the respiratory system, but that is not something that plays a role in the limb itself. So it's really just ectoderm and mesoderm. And then the limb itself is essentially, well, it's a three-dimensional structure. It's going to need signals to be able to pattern itself in those three dimensions. Those three dimensions being the proximal distal gradient, so going from the shoulder out through the elbow, out to the wrist, to the digits themselves. A dorsal ventral patterning. Ventral can also be termed palmar, so this would be essentially what we've been terming the palm of the hand versus the dorsum of the hand, the patterning in that dimension. As well as anterior-posterior. Now, anterior and posterior in the world of embryology actually are slightly different. Anterior refers to the thumb side and posterior to the little finger side. We, of course, once the limb has been rotated into anatomic position, term that the lateral portion of the upper limb and the medial portion, but in embryology, because of how the limb buds form themselves, we actually term anterior being, again, that thumb aspect of the hand, and posterior being the little finger aspect. So you can see here, we do have that ectoderm here on the outside, and the mesenchyme here being derived from that mesodermal tissue. That ectoderm, again, is going to ultimately form the skin, the sweat glands, and the hair, and that mesoderm from the mesenchyme will become that muscle, the bones, the blood vessels, and connective tissue. Not shown too much in detail on this particular slide, or at least something that we're not discussing as much, but just to point out here, we have what are termed somites. Somites are going to be these small segments essentially along the back surface of that embryo, and those are going to be differentiating to form the blood vessels, the muscles, the bones that ultimately go into each spinal cord segment. So we're going to have somites that essentially correspond to C5, C6, C7, C8, and T1 that ultimately are going to grow outwards and form the appropriate tissues within that upper limb. Also shown here is what's called the AER, or apical ectodermal ridge. We're going to look at this a little bit more in detail on the next slide. But notice that the AER essentially is at the distal-most portion of the limb. It's a bit of an outswelling, so I'll just erase that line there. You see there's a little bit of a swelling there at the end, and that's going to be very important for patterning, again, in that proximal to distal direction. So let's take a look at that. That apical ectodermal ridge, again, just to point it out, it is this extension here basically on the very edge of the limb, and this would be the furthest out portion of the limb bud. So this would be basically corresponding to what we would think of as being the tip of the fingers, although, as we'll see, how that patterning actually occurs is somewhat debated here. So here, the apical ectodermal ridge at that very end releases a particular growth factor called fibroblast growth factor 8, or FGF8, and that helps to promote growth of the limb, and it also is involved, we know, in some of the patterning in that proximal from the shoulder to distal, tip of the fingers, dimension. As a side note, not that this is a critical part of this course, but FGF8, and actually in particular the receptor to FGF8, is involved actually in the formation of dwarfism, or achondroplasia being the medical term. So we do also know that the gene, or at least the receptor for this particular gene, is involved in some other syndromes as well. So let's take a look at those limb regions. We've talked about this in earlier lectures back in lecture 2, but remember the upper limb is essentially divided into the arm, the main bone being the humerus, the forearm, the main bones of that being the ulna and radius, and then we have the hand, which we have composed of the wrist at its most proximal portion, that being composed of carpal bones and metacarpals. We don't see the carpals in this particular diagram, but remember they're just proximal to the metacarpals, and then the digits, which remember are made up of the phalanges themselves. For the dimensions you see here, again, the naming is a little bit different in embryology. Proximal and distal is basically the same, but remember, anterior, when we're talking embryology, is referring really to that thumb end, or what we would normally be calling the lateral portion of the upper limb. Posterior is referring to the ulnar side or the medial side of that limb. So it's a little different, again, in embryology than normal anatomy. So let's take a look at the two main models for how this limb actually differentiates over time. And as we're doing this, compare and contrast the two models. We'll look at some examples of syndromes that seem to support or go against the two different models, but recognize that we are not 100% decided as a medical community which model is more accurate, or if there are components of both, or if in all reality the true development of the upper limb is even more complex than either of these two models really illustrate. So the progress zone model essentially states that as this upper limb is growing outwards, we have this area referred to as the progress zone. It is directly underlying this apical ectodermal ridge, which you see labeled over here in the furthermost drawing. And the idea of the progress zone model is that clumps of tissue or portions of tissue are going to break off from the progress zone over time. And those that break off first are ultimately going to become the portion that is the arm. Those that break off second will ultimately become the forearm, and so on and so forth. Those that come off third will ultimately become the wrist and the proximal portion of the palm. And those that come off fourth are ultimately going to be forming the digits themselves. The idea here being that over time, again, those individual groups of tissue are going to break off. They will differentiate, changing from stem cells, cells that can turn into anything, into muscles, bone, blood vessel, and connective tissue. So differentiation is also an important term to point out here. Differentiation, again, refers to the transition of a cell from being a stem cell, I can turn into anything, into a differentiated cell, a cell that is committed to a particular lineage. I am now going to become a muscle cell, even if I'm not a mature muscle cell yet, but I am committed to becoming that. Or I'm going to become a bone cell, even if I have not become the mature bone cell, I am committed to becoming that kind of cell. So again, that the idea is over time, the longer a cell is in that progress zone, the further it's going to travel under that apical ectodermal ridge, the more distal it's going to end up, and therefore the more distal of a structure it's going to become. The arm cells come off first, the forearm cells come off next, the wrist cells come off after that. And recognize again, it's a little bit more complex than that, because even the cells that come off to become part of the arm become many different types of cells. Again, muscle, bone, blood vessel, connective tissue, etc. So here the idea would be that development is proceeding from the shoulder to the fingertips, that if we had some sort of interruption of this process, you're going to lose everything distal to that. If I were to cut off this model essentially at this particular point right here, then we really would just have development of the arm and the forearm and not get good development of the more distal structures because they have not really properly broken off and differentiated yet. So that's one model, but take a look at Amelia. Amelia is something that is well known historically, specifically from the late 1960s and early 1970s. And the primary reason for that is that it was highly associated with a medication that was used in pregnancy called thalidomide, and we'll look at that in a moment. Notice what's occurring here in Amelia. In Amelia, we have loss of the proximal structures, the arm and the forearm, but we actually still have retained distal structures, the wrist and the hand. You can see that essentially the wrist and hand here have been affixed to the shoulder with really no intervening tissue in between. We have loss of that arm and forearm. So this would certainly go against that progress zone model. The idea being that, well, if we had some interruption at the point where we have the formation of the arm, shouldn't we have loss of everything distal to that? If I am not able to have zone 1 essentially break off and develop, how could zones 3 and 4 further down the line actually be able to develop? So this certainly challenges that first model. There is, as I said before, a historical association with thalidomide. Thalidomide, again, is a medication that was used in pregnancy, essentially, for morning sickness. Unfortunately, the testing that was done had not really demonstrated enough of an association with phocomelia or limb deformities before it went to market. So there were many, many children who were born in the late 1960s and early 1970s who have very significant limb deformities caused, again, by this thalidomide, by this drug that essentially caused problems with differentiation. As a side note, thalidomide was removed from the market, but actually it does still find a place in medicine. We do use thalidomide in some cases of nausea that comes from cancer chemotherapy. It's something that we will not give to pregnant mothers, of course, and we actually use a safer version of the medication. Essentially, thalidomide comes in two different forms, one that really was causing the birth defect and the other that was more benign. We now really only give the more benign form, but even so we tend to avoid it in pregnant mothers because of this historical association. Phocomelia can also be genetically inherited, although that does form a smaller cohort of patients than those that are affected still from the thalidomide that had caused birth defects in the first place. And remember that progress zone model, again, just to drive this point home, if the idea in the progress zone model is that those tissues that form the arm are supposed to come off first, well then how do we get development of those more distal structures, the wrist and the hand itself, without getting the differentiation of the structures beforehand? So then it certainly opens the place for another model, and let's take a look at that. The other one is prespecification. And the idea in the prespecification model is that it's not that the apical ectodermal ridge is causing each individual portion of the upper limb to break off and then develop into those tissues. The idea is that the apical ectodermal ridge is there, and it's involved in patterning, and it's involved in signaling, so maybe it's a proximity to the apical ectodermal ridge that determines what kind of tissue it becomes. But even before we actually have true growth of the limb, it's already been determined what those different cells are going to be becoming. So here, portion 1 still is the arm, portion 4 is still the hand, but notice that even before the limb has truly grown all the way out, each of those different layers essentially is already there, that we already have those different regions predetermined, pre-specified, and as it grows outward, it does more differentiation into the actual tissues that make up the arm, or the upper limb. So here, the mesodermal cells, again, have already essentially decided where they're going to be based on their location, even before the limb bud grows. Each segment is going to basically expand rather than newly form as the limb bud grows. And so, again, in this particular model, the apical ectodermal ridge is still playing a critical role. Perhaps part of it, again, is that proximity, that if you are closest to the apical ectodermal ridge, you may get very high levels of FGF8, and therefore become hand. Whereas if you're very far from the apical ectodermal ridge, you may get very low levels of FGF8 just because they're not able to diffuse as well that far. And therefore, that's going to be an area that gets determined to be arm. But again, the idea is each of these different portions of that upper limb has already been essentially specified to a particular destiny. So let's look a little bit more just at some of the development of the hand. We talked about this before, but remember, it's apoptosis or programmed cell death that's going to actually cause the formation of the individual fingers. That as the hand or as the foot is developing, that we start with a little bit of a notch right at the very distal portion here, but that as programmed cell death occurs, growing more proximally between those digital rays, we're going to be able to form 5 separate digits here with loss of those web spaces. So what if this process goes wrong and we don't get proper separation? Well, there are other limb defects. We'll look at some of the things that occur with loss of web spaces, but let's just take a look at even more significant loss of limb problems that can occur, congenital defects that occur secondary to essentially a complete absence of the limb. This is termed Amelia, A being the absence of, melia referring here to the limb. And this is, again, a complete absence of the limb. Often it is symmetric, affecting both sides. It may, again, affect both the upper limb and the lower limb, or it may be unilateral. You see in this particular infant, they do still have retention or maintenance of one of the upper limbs, but they do have loss of the other upper limb. We could also see some other portions of the upper limb just being completely absent. So that would include, for example, absent radius. Here we still see the ulna, but there's no other bone in the forearm. We should be seeing a second bone again here, the radius that is going to be residing on the thumb side. We don't see the radius here. Generally, absent radius is commonly associated with certain genetic syndromes. For example, thrombocytopenia with absent radius syndrome. Now, thrombocytopenia refers to low blood platelets. Thrombocytes are platelets. They're involved in the clotting of blood, along with some proteins that are produced by the liver called clotting factors. A lack of thrombocytes or a lack of platelets can cause bleeding problems. In particular, it can cause problems with delayed bleeding, that the patient here may bleed for some time, they may be able to clot it with the proteins, but the platelets are really involved in stabilizing the wound here. So this may be somebody who has a problem with delayed bleeding. Fanconi anemia is something that also can be associated with an absent radius. Anemia refers to a low red blood cell count. So these are patients who often their bone marrow has been impacted and they have difficulty with formation of red blood cells. And finally, Holt-Oram syndrome. Holt-Oram syndrome often has findings in the heart as well. It's sometimes called heart and hand syndrome. Oftentimes, these patients will have an atrial septal defect. That's a hole between the two top chambers of the heart. A ventricular septal defect, a hole between the bottom two chambers of the heart, or may just have other heart deformities as well. So this absent radius is often connected to a larger syndromic finding, other clinical findings that may occur in these infants. Finally, let's take a look at those digits themselves. I mentioned that the web spaces may have difficulty regressing, and that can result in syndactyly, which we'll look at in a moment. But we also can see polydactyly. Polydactyly is having extra digits, and you can see we have what can be termed a preaxial polydactyly. Preaxial referring essentially to being on the thumb side or on the radial side. This patient has almost an exact duplication of their thumb. Or on the other hand, we could have a duplication within the hand. Here, essentially, what appears to be the third and fourth digit look essentially like a duplication of each other. You can see that we've got 6 digits here overall. So polydactyly, again, is having extra digits, having too many fingers. Here, it's 6 with essentially a duplication within the hand. Polydactyly can certainly be even more dramatic. Here you're seeing it in the lower limb in a foot, but you can see what's termed mirror polydactyly, and you can certainly see where the name is coming from here. We have what's not exactly anatomically a normal foot, but not that far off. But you can see that we've essentially mirrored some of the digits of that foot onto the other side here. So we have quite significant polydactyly with 8 digits overall, essentially having 3 mirror digits and 5 more or less normal digits here, in this case the foot. We mentioned before syndactyly as well. If those web spaces do not properly regress, if we don't get the apoptosis between the individual fingers, then we can end up with some fusion of the digits. Now, certainly it can run the gamut in terms of its severity. Syndactyly could be, on the one hand, a relatively slight thing, where here you can see really at just the most proximal portion of the digits here, we still have fusion between the 4th and 5th digits. Actually, a very common place to see syndactyly is outside the upper limb, but in the lower limb between the 2nd and 3rd digits there. That's something that's actually very common across the general population. A little bit of syndactyly there where the web space hasn't totally regressed. But syndactyly certainly can be far more severe. You see on the other side here that we actually have essentially complete fusion of most of the digits with a shared fingernail at the end. So this is very profound syndactyly. You can imagine the function of the hand on this side is going to be significantly limited by essentially the lack of separation of the individual digits here. So that's it. In our next lecture, we're going to take a look at some of the extrinsic causes of limb malformation. But for now, remember, these are the main things that can occur within the organism, within the developing fetus, as intrinsic causes of limb malformation.